Like Dr. D said, this came about as a patient of ours was on, she was on 10 milligrams of prednisone for polymyalgia and had been therapeutic at that level, and when we took her off of it, had severe issues with range of motion. She couldn't get out of bed, so as I asked Dr. D what to do, he said, well, you tell me, and this is how this began. So we are going to learn about steroids, and we're going to start with our talk about wounds and the healing process. Just a little background information about wounds. So the definition of a wound is a disruption of the normal structure and function of the skin and underlying soft tissue. But there are several different classifications of wounds. So there's an open versus a closed wound, depending on whether the underlying tissue is exposed to the outside environment. There's an acute or a chronic wound. So acute wounds heal without complications, and they transition through the process of wound healing that I'm going to go through in the next couple of slides in a linear fashion without halting. Chronic wounds take longer to heal and usually halt at one of the stages of wound healing and fail to progress any further. As far as surgery, there's also clean and contaminated wounds. So we usually close clean wounds to help them assist in their healing process, whereas contaminated wounds are usually the ones that we pack and leave open to drain. So the process of wound healing takes 6 to 24 months from the time of injury. Sometimes it can take even longer depending on if it becomes a chronic wound or not. And so there are 4, depending on what source you use, there's 3 to 4 phases of acute wound healing. And so we are going to go through those a little bit in detail. So the first phase is hemostasis phase. It occurs immediately after the injury, and it is the process of the wound being closed by a clot. So the damaged blood vessels vasoconstrict or close down. The platelets aggregate in the wound, and then your body triggers the coagulation cascade to reinforce the clot with a fibrin mesh. The platelets also release mediators to attract different cells to the site to help with the repair process. The inflammatory phase is completed in less than a week of injury, except if it is infected or in chronic wound. So the main process in this stage is you destroy the bacteria and remove the debris from the wound, and it prepares the wound bed for growth of new tissue. So there's a transudate, which is just a mixture of white blood cells and proteins and different growth factors that is released from the vasculature in the area as they become more permeable, and it allows blood cells to enter the site of the wound to assist in the repair process. And this is when you get those associated symptoms of inflammation, which are swelling or edema, redness or erythema, heat, and pain. The third phase is the proliferative phase, which lasts anywhere from 4 to 24 days. And in this phase, you fill and cover the wound with new tissue, and the deep red granulation tissue fills the wound bed. So in this stage, one of the important things to remember is the collagen is disorganized and the wound is thick, and you'll see when we move to the next phase how that changes. The wound contracts, which means it pulls itself together towards the center of the wound from the outside. New blood vessels form and allow the granulation tissue to receive sufficient oxygen and nutrients so that it can heal. And then slowly the epithelial cells cover the wound. And it's noted that during this phase, when the epithelial cells continue to cover the wound, this happens much faster when the wounds are kept hydrated. So one of the things that I know we do a lot with our wounds is we apply betadine, and in this phase, we actually need to focus more on moisture to help with this proliferative phase than drying it out with the betadine. The last phase is the maturation or remodeling phase, and that begins 21 days after the initial injury and can continue for a year or more. In this phase, new tissue gains strength and flexibility. The collagen becomes aligned, whereas in the last slide, we stated that the collagen is disorganized. So now the collagen is aligning along tension lines to help the wound continue to contract and close. And then water is resorbed so the collagen fibers can cross-link, which gives you the strength of the wound so that it doesn't break open. And then hopefully, if all goes right, your wound heals. So this is the 4 stages and like a little timeline and the high points. Just a little picture to help with the learning. Some factors that affect wound healing include age. So as you get older, the skin thins out, and you also have a decreased inflammatory response. So some key nutrients that are needed, obviously we get a lot of our vitamins and stuff in our diet. So some supplementation with zinc, folate, and vitamin C are some of the vitamins and minerals we ask patients to use if they need some additional nutrients. Obesity puts you at a greater risk of infection. Repeated trauma, obviously, you can only heal it so many times before it breaks down. Skin moisture, like we talked about, dry, thick skin and overly wet skin are at risk for infection. So we try to balance those with the different phases of wound healing. Smoking, because what does smoking really do in any good sense? Chronic diseases such as cardiovascular diseases, diabetes, and immunodeficiency states. And then medications. So NSAIDs interfere with the inflammatory stage, which we just learned is important for wound healing. Anticoagulants disrupt blood clotting, which was the first phase. And then immunosuppressants weaken the immune system and increase the risk of infection, which is what this is all about. So you may be thinking, I thought this was about steroids. We're going to get into that now. So steroids are have several properties, including anti-inflammatory properties. So they prevent the release of substances in the body that cause the inflammation, which helps with the wound healing. They suppress the immune system by preventing the proliferation and growth of T cells. And then they have several metabolic effects. So they raise your blood sugar, increase water excretion, increase your blood pressure, and maintain your cardiac output and heart contractility. So this is just a picture of how all of those things work together in a cycle, and we're going to go through a little bit more of that. So there are several different types of steroids. There's short-acting, intermediate-acting, and long-acting or systemic steroids. Those are the different names of the different classes, but the prednisone is the one that's most often used in patients. So there's a low dose, a moderate dose, a high dose, and a massive dose based on their weight that can be given. I also put this this little conversion. So the prednisone, 5 milligrams is equal to what conversion in the different classes of steroids. Chronic steroid use is doses of greater than 10 milligrams for greater than 1 week. In this presentation, Miss Kathy was a chronic steroid user. She was taking 10 milligrams for 6 weeks at the point that she came in for surgery. So, in surgical patients, normal cortisol secretion or steroid secretion that comes naturally through the process is 8 to 10 milligrams per day. So the normal response to surgery is a prompt increase in the secretion of cortisol with the onset of surgery. For minor procedures, it's 50 milligrams per day, which normalizes within 24 hours. For major surgeries like our surgeries, the body produces 75 to 150 milligrams per day, and it normalizes by post-op day 5. The adrenals are capable of secreting up to 300 milligrams per day, which is equivalent to 75 milligrams of oral prednisone, but rarely exceeds 200 milligrams per day, even in response to a major stressor like a major surgery. The normal rise in cortisol after surgery lasts about 3 days, but the greatest rise occurs during the reversal of anesthesia, extubation, and in PACU, mainly in response to pain. So by taking prednisone or exogenous steroids, you basically are inhibiting your own process of producing steroids. So it's a negative feedback loop, which is in this picture at the bottom. So your steroid therapy causes suppression of the HPA axis, or the hypothalamus pituitary adrenal axis. So the body's natural response to stress and surgery is reduced. You're unable to produce enough cortisol in response to the magnitude of the surgery, and you end up in an Addisonian crisis. In awake patients, this looks like altered mental status, abdominal pain, nausea, vomiting, and weakness. In an anesthetized patient, it could be just severe persistent hypotension that's poorly responsive to fluids, and circulatory collapse, which means death. So preoperatively, what we want to do for our patients is we want to find out the dosage of steroids and the duration that they've been on the steroids. And so of note, there are different doses of steroids that are used in different disease processes. So patients who will not require stress dose steroids for surgery to make up for the fact that they are not producing enough steroids naturally because they are taking steroids. include patients who take prednisone less than 10 milligrams daily and patients who stop their steroids more than 3 months prior to surgery. Patients who will require stress dose steroids include patients taking at least 10 milligrams daily of prednisone or more, steroids 10 milligrams daily within 3 months of surgery, patients with diagnosed secondary adrenal insufficiency, which is diagnosed by an ACTH stimulation test, and patients on high-dose inhaled corticosteroids, which is at least beclomethasone 1.5 milligrams per day or more. This is just some information. This is how you would test to see if a patient was actually suppressed based on their therapy. We don't do this testing. They say testing is recommended for patients who take 5 to 20 milligrams of prednisone or equivalent daily, who take topical steroids or use inhaled glucocorticoids. But the testing usually is just, it will tell you if they're suppressed or not, but either way, we're usually just going to give them stress dose steroids. So a lot of people don't even use testing, but this is information in the event that we would need to do testing. All right, so as far as stress dose steroids, we need to discuss the plan for perioperative steroids with anesthesia. For a major surgery such as ours, we would ask patients to continue their home dose of steroids preoperatively, and then we would give them stress dose steroids at a dose of 100 milligrams IV at induction and then 50 IV every 8 hours for 24 hours. After that period, we would monitor them and then taper their dose by half each day until they reach their home dose, and then they would continue on their home dose that they were on. We have a similar process here at St. Charles. So we do 100 milligrams Solu-Cortef at pre-op and then 50 to 100 milligrams every 8 hours after the initial dose based on the degree of suppression and stability. So the higher dosage of oral steroids that you're on, the more that you would need continuously after the induction dose. And then the risks associated with excessive steroids, stress dose steroids, include postoperative infection, which we know that's what this is all about, GI bleeding or an ulcer, and then delayed wound healing. So this is some literature that some I got from Dr. D, some I used on my own. So these are two important articles that I used. One was a systematic review, and one was just approaches based on evidence. Basically, in all of the literature, both showed that patients receiving therapeutic doses of steroids who go through surgery do not usually require stress dose steroids. It takes a lot for you to be suppressed to the amount that you would need stress dose steroids. Only patients who receive replacement doses of steroids due to the diseases of the HPA axis require stress dose steroids. However, if suppression is a concern, there is minimal risk associated with administration when compared to the risk of circulatory collapse. So basically all the literature says is, hey, you probably don't need the stress dose steroids, but the risk of not giving them to you and you having circulatory collapse is way worse than us giving it to you. So we usually give stress dose steroids, which is another reason why a lot of people don't do the testing that we talked about. This is a little bonus information I threw in there. This is talking about steroid tapers. So a lot of patients will stay on their steroids if they're on low-dose long-term or chronic steroid use. But in the event that a patient is on a short term of steroids, this is how you would taper their dose to get them off of it. So you would taper them for 3 to 6 weeks with monitoring twice weekly. It can be discontinued, or a slower taper can be considered based on the results of testing and symptoms. So the symptoms of stopping steroids without tapering include all of those at the bottom. And this is just an example. So if a patient was on 40 milligrams, you would do the 40 milligrams and then drop them to 30, 20, 15, 10, and 5. And then you would stop them. But it's a gradual process that requires a lot of time, which is a part of the reason why patients have symptoms. So let's talk about steroids in wound healing. So steroids suppress the cellular wound responses. They reduce wound contraction and interfere with collagen synthesis and deposition, so you heal with incomplete granulation tissue. It also interferes with the regenerating capillaries and epithelial cell migration. So, in other words, it blocks 3 of the 4 final processes in wound healing, which is why we give patients these. So patients are treated for 30 days prior to acquiring a wound, have a twofold increase in wound infection, 2 to 3 times higher incidence of wound dehiscence, and a 4 times greater mortality. So who is not affected by steroid use if they have wounds? They do not cause wound healing complications in patients who have used steroids for less than 10 days, even high doses, steroid use for greater than 3 days after the wound is acquired, and steroid use in patients with a closed or sewn wound. So basically, if you acquired a wound and it was closed and then you started on steroids, you would not have an issue. But being on steroids preoperatively and then inflicting a wound causes the wound healing issues. So avoiding complications, we could have patients discontinue their steroids for close to 12 weeks prior to surgery, but then we would have a recurrence of their symptoms that they're being treated for, which is what happened with Miss Kati. Or we could supplement with vitamin A. So vitamin A is one of several fat-soluble vitamins found in many foods, including meat, fruits, and vegetables. 90% of the body's vitamin A is stored in the liver, which is important for us because we will have to determine patients' liver function prior to giving them vitamin A, and we'll go through all of that in a couple more slides. So vitamin A is essential for normal vision, particularly night vision, immune response, epithelial cell growth and repair, reproduction, and proper functioning of your major organs. The recommended daily index is 5,000 international units per day. Most of us get all of that in our diet. Vitamin supplements contain different doses. Some multivitamins contain 3,000 to 5,000 international units, and then there are separate vitamin A supplements that contain anywhere from 5,000 to 25,000 international units. There are also topical vitamin A creams that cause drying of the skin and exfoliation, and they help build collagen fibers to restore elasticity, hence improving the appearance of wrinkles. So vitamin A in wound healing basically turns on all 3 of the last processes that the steroids inhibit. So it enhances the early inflammation response, increases fibroblast differentiation and collagen synthesis, and promotes epithelial cell differentiation. Basically, they counteract the catabolic effects of steroids. So recommendations for patients using steroids, we would ask our patients to continue their home dose of steroids and not stop it, which I did. We would supplement with 5,000 international units for 14 days pre-op, which Miss Kati was taking in a multivitamin, but there are different supplements, like I said. We would give them 10,000 international units while they are inpatient after receiving stress dose steroids, which Miss Kati got while she was here. And then we also would prefer that they use 5,000 to 10,000 international units daily for 14 days post-op. I recommend 10,000 units because at this point you've already acquired a wound, so you would need more than the initial dose preoperatively when they did not have a wound. But for Miss Kati, she just continued to take her multivitamin, which had 5,000, and she did okay. So 25,000 international units daily for 10 days is recommended in the setting of high-dose steroids or patients who have a vitamin A deficiency. Patients who should not receive vitamin A include patients who have hepatic diseases or who have elevated liver enzymes. So preoperatively for these patients, if they are on low-dose steroids, we would need to get a CMP to evaluate their liver function tests. If their liver function tests are elevated, we would need to discuss our plan with the surgeon and maybe change it. So we may need to change or delay the procedure, cancel the procedure, or increase monitoring for wound complications. Patients taking anticoagulants also should not receive vitamin A due to the risk of bleeding. Patients who have conditions that affect their ability to absorb nutrients from their food, different bariatric patients who had sleeves, or if they have had part of their colon removed, or if they have any issues with absorption. Patients with alcohol abuse and patients taking other prescription retinoids like Accutane and Retin-A should also not receive vitamin A due to the toxic levels. So speaking of vitamin A toxicity, the acute toxic dose of vitamin A is 25,000 international units daily for 8 weeks. The chronic toxic doses are 4,000 international units daily for 6 to 15 months, depending on the patient. So symptoms of toxicity that we would look for include vision changes, bone pain, poor appetite, nausea and vomiting, dry, rough skin, sensitivity to sunlight, and dizziness or headaches. That is all I have. Any questions? I hope you all know everything you need to know about steroids and vitamin A.